Hello, everyone, and welcome to our live session today. I will be going over a quick startup presentation to welcome you all and introduce you to our program and opportunities if you've not previously attended one of our shadowing sessions. So Pre-Health Shadowing is a student-led, minority-led, women-led nonprofit dedicated to helping prospective healthcare professionals gain access to educational resources, no matter their demographic status, abilities, or location. My name is Ali Marcotte. I'm the Assistant Chief Volunteer Coordinator at Pre-Health Shadowing. Thank you all for attending today, and let's get started. Just a little PSA, we do have closed captioning for all of our sessions to accommodate all students. This setting is available on the bottom of your Zoom screen. If you need assistance enabling the transcript, please direct message one of our team members. We're always looking for ways to be more inclusive and ensure our sessions are accessible to everyone. So please, if you have any recommendations for how we can improve, you can email us at info@prehealthshadowing.com. Since this is an international program, we want to know where you're Zooming from today. Go ahead and drop it in the chat. I'm calling in from Virginia. If you can follow us on social media, we're active on Instagram and TikTok. You can also sign up for our email list on our website and never miss a session. We also have some wonderful opportunities for you all as benefits of being a part of our program. We've partnered with Kaplan to get our students a 10% discount code that can be used on all Kaplan products, as well as free resources such as study guides to help prepare you for standardized tests like the MCAT, NCLEX, or PCAT. If you fill out our short survey in the chat, we will get you signed up for these deals for free. We would also like to draw your attention to another amazing program, Neolith. Neolith is an online mental health platform for students. College and young adulthood is stressful enough as it is, even in non-pandemic times. For pre-health professionals especially, we know this path isn't easy, and that's why we've partnered with Neolith to spread the word and offer free access to their services if you use the link in the chat or enter the code PREHEALTH when signing up. Mask for Mask is an amazing women-led organization that donates 4 masks for every 4 masks sold. They go to people in need during the COVID-19 pandemic, those in the homeless community, healthcare workers without proper PPE, and others who are struggling to stay safe. With our discount code PHS15, you can get 15% off your order. If you buy through this method, Pre-Health Shadowing will also get 10% of the proceeds, which is amazing because we are a nonprofit that runs solely off the support of our community. If you want to play a bigger part in supporting PHS, we would love for you to join our network of student volunteers and team members. You can apply to be part of our administrative team and lead students in various projects and initiatives with professional outreach, grant writing, and more. We understand that as a pre-health student, you may not have the time, so we also offer the opportunity to volunteer asynchronously with tasks that can be done on your own time. We'd love to have you be a part of this program and contribute your own unique perspective. If you're a high school student and want to get involved, we've started a program called HTP, High School Training Program for PHS, which allows you to connect with college pre-health programs, get involved in fundraising for PHS, and organize resources for other high school students interested in medicine through pre-health shadowing. We want to recognize the hard work of all of our students in the program, so if you're interested in getting published, you can submit essays, reflections, research papers, and reviews to our editor-in-chief through the link dropped in the chat to have your work on our website. This will look great on CVs, applications, resumes, etc., so please take advantage of this. Part of our mission at PHS is to promote diversity, and in order to do this, we've launched an initiative to have monthly panels to celebrate different demographics in the field of medicine. Some of these upcoming events include a series on patient experiences, a COVID-19 roundtable, and international student forum. If you have a mentor, professor, or professional that has inspired you and think could contribute to these conversations, nominate them today using the link in the chat. If you can, we humbly ask that you donate to our program. As you know, pre-health shadowing is completely student-run, and we are working around the clock to keep this free and accessible to everyone. Unfortunately, Zoom and our website are not free, so any contribution you can give would be greatly appreciated. If you're not financially able, we request that you send this link to someone you think can, so we can continue to support those who cannot afford similar opportunities. Throughout the session today, we encourage you to drop any questions you have for the speaker in the chat. Our team members will be making note of these to be asked in the latter half of the session. Take good notes as our professional is going over their presentation, as there will be the chance to take a post-shadowing assessment to verify your virtual shadowing hours. More information will be available on this at the end of the session, so stay tuned. Lastly, if you can, we request that you turn your cameras on. This is by no means an obligation, as we're respectful of different circumstances, but it does help us feel closer together in a time when socially distancing is mandatory. I appreciate you all for listening, and now I would like to welcome our professional today. Thank you so much for joining us. You may share your screen whenever you're ready.
Thank you. Can everyone hear me?
Yes.
Perfect. Okay, let's see. We're going to make the technology work. I'm pretty sure this is going to happen. We'll see. So you should be able to see my slides go up and down. I can't believe it's happening. And great. Okay, and then this, and then you can see my mouse. Okay, so I'm going to minimize this over here. So thank you so much for reaching out. I'm very happy to be here today. My name is Phil. Is my name that my friends call me. Please feel free to call me Phil. My given name is Felix. I'm a certified PA. I'm full-time faculty assistant clinical professor in the PA program at UC Davis, and we're housed within that last acronym stands for the Betty Irene Moore School of Nursing. We are housed in the School of Nursing. We actually, at this point, have a combined program where NPs and PAs are essentially taking about 95% of the coursework side by side. We also have an interprofessional program, and our students take instruction and take classes alongside nursing students within our Masters of Nursing program, medical school students, and then we also interface with some pharmacy residents. So it's really an interprofessional program. So my background is really very typical of a PA. I was in the military as a corpsman. I actually got to serve in Southeast Asia towards the end of the Vietnam War, and did not initially want to go into medicine at all. It was really a matter of circumstance, or even luck, if there's such a thing. Ended up going through the physician assistant program, or PA program, in the Air Force. I have been around a bit. I graduated in 1984, did 4 years of family practice, then did a year postgraduate training in orthopedic surgery, and I retired from about 30 years of clinical medicine in practice in the field of orthopedic surgery and sports medicine. But I've also been interested in teaching and have been involved with the PA program at UC Davis in some capacity since the early to mid 90s. And I have been full-time academics for the past 2.5 years. So I could have entitled this, session objectives, but really I'm thinking, questions that you might have, what exactly is a PA? How did this get started? What is the training like? What types of things does a PA do? And a question that comes up very frequently is, so how is a PA different than an MD? How is a PA different than an MD? So what I'll try to do today is navigate through some of these questions. Please feel free, and I would encourage you that if you have any questions on your end, just submit them in the chat room, and then we'll have an opportunity later on to hopefully answer those, and hopefully have a two-way discussion. So what is the PA? So the term PA stands for either physician assistant or physician associate, depending on where you are in the world. My degree actually says physician associate, and in Europe, their term physician associate, but the term physician assistant is used in the United States. And when you see the letter C after it, it means that we're certified. And our certification involves a couple things. You initially have to pass the certification exam, which is fairly comprehensive. It's about a 400 question exam to get licensed. And then this recently changed. We used to have to retest, take the exam every 6 years. that now got pushed back to every 10 years, but we recertify by submitting documented CME hours every 2 years. And we have to have 50 hours of category 1 CME every 2 years in order to maintain our certification. All right, and some of this is right off of the AAPA, is the American Academy of Physician Assistants. And so some of this I just captured right off of the website. So PAs are medical professionals, and what we do is we diagnose illness, we develop and manage treatment plans, we prescribe medications, including controlled medication. I have a active DEA license, and oftentimes we serve, especially in the primary care environments, we serve as the patient's principal healthcare provider. We have thousands of hours of medical training. We're very versatile. You'll find PAs working in multiple different fields, and I'll touch on that a little bit later. And we work really in a collaborative environment with physicians, get along very well. And I think that our relationship with the physicians that we work around, truly it centers around collegiality. That has certainly been my experience. PAs practice in every state, in every medical setting and specialty. And one of the impetuses towards the development of the entire field and concept of the PA was to really improve healthcare access and quality. One of the thrusts that we have in the UC Davis PA program is serving the underserved, and a very high percentage of our graduates do just that. And they end up going to underserved communities and functioning within a primary care specialty. So, and then you can get on the website and get a lot of this information without being a member. And if you scroll down, it has additional information. So that's why I included the last line. Really, if you have an interest, I would recommend that you look up the American Academy of Physician Assistants and go on their website. There's really a amazing amount of information that you can access without having to be a member. The definition of physician assistant or physician associate in Wikipedia is a type of mid-level provider. We diagnose illnesses, develop and manage treatment plans, prescribe medications, and again, may serve as a patient's principal healthcare provider. So we are nationally certified. We take a national certification exam that is administered and regulated by an independent organization. And we literally practice medicine in collaboration and led by the physicians that we work with. We are educated at the graduate level, and we practice again in nearly every medical specialty and setting. So really, I think to our patients, the way that we do things and what we're able to do is not significantly different than MDs or DOs. We conduct physical examinations, take a history, diagnose and treat illness. We are able to order and interpret tests. We do counseling on preventative health care. And I would say that one of the things that does make the PA field a little bit different is that we are, I think, a little bit more focused on a holistic approach and preventative health care. We assist in surgery. We can also do minor surgery independently. We write prescriptions, as I indicated before, including category 2 controlled substances. We also can get certification for medically assisted treatment of opioid use disorder through the use of Suboxone. In fact, I'm going to be leading a session on the 28th of April for our students, where they're going to be able to fulfill the requirement for MAT training to be able to become subscribers for Suboxone. We make rounds in nursing homes and hospitals. We obviously can obtain medical history. What you will find is that our responsibilities and what we're able to do really mirrors that of our collaborating physicians practice. So for the 4 years that I was in family practice, that's essentially what I did, was family practice, and that included obstetrics. once I completed my orthopedic training, then really my practice was focused on orthopedics and sports medicine. So how did this all start? Well, it all started in 1967 at Duke University, and we really owe our existence in large part to a single human being. And I think one of the lessons here is that, you know, we can get lost in the crowd and think that maybe we can't make a difference, or maybe we, the individual, doesn't matter. But really everything starts with the individual, and everything starts really with a single person having an idea and really having the not only energy but the courage to put this forward. So Dr. Stead had an experience of working with military corpsmen in Southeast Asia in the military. And we, as military corpsmen, we were trained to obviously be the first responders for battlefield injuries and really evaluate the patient, treat them, and stabilize them until they were able to get back to either a secondary or tertiary treatment facility. Well, the problem was that when these highly trained and motivated and really smart corpsmen got back to the United States, there was no civilian counterpart that matched what their advanced skills and experience really qualified them to do. So we found a bunch of highly trained people, when they came back and wanted to continue their career in medicine, they really had only two options. One was to become an EMT, and in fact, many of us did become EMTs, and the other one was to become a hospital orderly. And really, neither of those things completely utilized the skill set that we had. So at the same time, so Dr. Stead saw this group of people who had amazing abilities that were underutilized, but also there was, at this very same time, and it really persists through today, really a lack of healthcare providers, really at the most basic level within primary care. So Dr. Stead, who I think was a genius, developed a concept of a training program where military corpsmen, and the first class was comprised of corpsmen from the Navy, were put through a rigorous course of training that at that time was 24 months, that brought these corpsmen into a position where they had now the training and the skills that they could serve as primary care providers. And the one thing that I do want to indicate to you is that our training is along the medical school model. And in fact, the program that I went to, we took the basic sciences in the same cohort as the first year medical students at the University of Oklahoma a long time ago. So what are the prereqs in terms of today of getting in? So at this point, you have to have chemistry, at least general chemistry. We are actually going to change this in our program. We're going to require organic chemistry as well. You need to have at least a year, and it has to be a lab-based course of anatomy and physiology. You have to have basic biology as well as microbiology. You definitely need to have a GPA above 3.0. You're not really going to be competitive below 3.5. We in our program do not use the graduate review exam. I know for medical school you take an exam called the MedCat. We do not use any exam in terms of our admissions process. I am on the admissions committee. Interestingly, the most recent thing is there actually is now a pilot program to use a pre-PA exam that really is modeled along the MedCat, the MCAT. We'll see whether or not that pans out. But in order to get into our program, and I'm strictly speaking about the UC Davis program, and we're the only PA program in the UC system. There is one in the California state system, which is relatively new, and that's at Cal State Monterey Bay. But in the class that's going to matriculate in July of this year, we had over 2,000 applicants for 65 slots. So it was highly competitive. We look at the entire program. Our admissions process is holistic in nature, and we really try to have our classes mimic the community around us. And I think that we have really achieved that goal. And I think that in doing this, what we are able to do is graduate providers that that patients can come to that really look like them, have a culturally or similar to them. And really, we emphasize the concept of providing culturally competent and sensitive care. There's been a proliferation of programs within the USA. There are currently 260 programs accredited. That's the most recent data when I went and looked at the website for the specific organization that monitors that. There are several programs that are in the process of being developed. The UC Davis program is fully accredited. We have been in existence since the 1980s. So what is the training like? It is a master's degree program, again, using the medical model, although there is starting to be a trend where the programs are becoming a little bit longer and the students are graduating with a doctor's in medical science. That is the minority. The vast majority of programs are master's degree programs. They range in length from 27 to 36 months. And again, that 36-month program are those programs that are adding some doctoral coursework so that students graduate with a doctorate. In our particular program, the first year is on campus, and it consists of didactic material as well as learning, practicing, and really refining clinical skills. And that's what I do in the program. I run the clinical skills courses for the first year students. The students then go on rotation, and they go on rotations for up to 2,000 hours, which is a fair amount, but as most of you probably can appreciate, you know, there's the science of practicing medicine. What might be more difficult to figure out is really the art of practicing medicine, especially in this country, in our environment. So in terms of credentialing, again, we have to take and pass a comprehensive national exam. The NCCPA is the independent organization. That's a national council on accreditation for physician assistants. Again, you have to take it at graduation, and then you have to retake the test every 10 years. The test itself is on general medicine. It covers all of the different fields. So even someone like myself, who'd been in orthopedic surgery and sports medicine for 30 years, you know, had to go back and take a test that covered all fields, including, you know, things like endocrinology, dermatology, women's health. And I felt like that was valuable. And what it really does is it makes every PA out there have a baseline level of competence and knowledge in general health medicine topics. Recertification, again, occurs every 2 years, and that's through CME. PAs are licensed by individual states. Most of the states have PA boards that not only issue licenses, but take care of maintenance, and also if there are any disciplinary actions that need to be carried out if anybody gets into trouble. So one of the questions may be, so, you know, to expand a little bit, exactly what does a PA do? So here is a little graphic that I found. So, and again, in the upper left hand, so we really prioritize patient education and preventative care. Some of the things that practices have seen, and as you're probably well aware, the at least in the United States, the idea of having independent, physician-owned, physician-run practices is starting to become more and more rare, and things are becoming more centralized and corporate, if you will. But regardless, the practices and the individual physicians are finding that by bringing on PAs, we are able to significantly decrease wait times. So we perform patient assessments, and again, order and interpret laboratory tests, including imaging labs and more. We do diagnose, and we formulate treatment plans based on that diagnosis. And also that may include prescriptions. We first assist in surgery. In my last employment, it would be very rare to have two surgeons in on a surgery, even on very big cases. And honestly, I was trained by experts really to be the best first assistant that I could be. And after 25 years of experience, I felt like in some ways I was actually a better first assistant than some surgeons, because there was no competition in terms of who was going to actually do the case. We do perform procedures and interventions, and we work in virtually every field that you could think of. And so again, in the upper left here, I'm not going to go over that, but we see a lot of patients. We see a lot of patients. The most recent data was 8.5 million patient visits a week. So that's now up above 450 million patient visits a year. The top 5 practice areas by specialty, and this is by design, include family medicine or general practice, and then followed by surgical subspecialties, internal medicine, emergency medicine, and dermatology. And you can see in the lower left, it indicates kind of where we are mostly found, concentrated in the northeast, the southeast, and then the west. The average graduate is getting 2 to 3 job offers, so the demand is really high. We've had a 54 increase in certified PAs in terms of just raw numbers in the last 10 or 11 years, and with the explosion of programs, really that's considered to be on the uptick. Interestingly, U.S. News and World Report each year prints a list of it prints an edition with a list of the best jobs in America, and the most recent edition, the PA field was rated the best job overall in America. 97% of PAs retain their certification throughout their career, and again, we have to earn 100 hours of CME credit. 50 hours of that have to be category 1, and what that relates to is really attending conferences, either live or virtually. The median age of the PA is 38 years old, so we're getting a little bit older. So I think that for those of you that are young, it represents really an incredible opportunity. Interestingly, there's been a complete change in terms of the demographic, male versus female. And I'll tell you that when I first went to national conferences, let's say through the 80s to early mid 90s, the vast majority of attendees at those conferences were males. And now 68% of all PAs are female. And I will tell you that in our class that just is finishing their first year, that number is up between 70 and 75%. And I think that, and I've asked the students, so, why did you choose this career field over others? And some of the answers have been interesting, especially from our female students. And the other thing about the PA career field is because you have this varied skill set, 13% of PAs actually work more than one clinical position. So they may be in an organization where they'll work 2 or 3 days a week in internal medicine, and then they really love dermatology, so they'll spend the other 2 days in a week working in a dermatology clinic. almost a quarter of PAs have a second language. So that really our ability to communicate with our patients. So let's talk about that a little bit. Not only in theory, but in essence of what our patient experience, what happens in clinic. We do a good history and a physical, figure out what's happening through evaluating diagnostic testing, develop a treatment plan, and perform some medical procedures. So some of the differences is that for larger cases, we don't actually do the surgery, but we first assist during surgery. For minor surgery, I worked in Washington State where I had my own, 2 times a month, I had my own clinic, if you will, in the minor surgery room where I was able to do minor surgery without assistance. This last line right here is changing. You may or may not know, but the NPs are currently legislating for full practice authority, or FPA. The PAs have taken a little bit of a different approach. We value the collegial relationship we have with physicians that have really, for both us, the physicians and patients, the past 50 years, and PAs have been around now for more than 50 years. So what we have is OTP, which stands for optimal team practice. But honestly, I don't think that Dr. Stead could even have imagined what the evolution has been of the PN from a dependent or supervisory relationship to one that is more collaborative and collegial. So in a lot of the legislation, that word supervision is going to be replaced with collaboration. And I think this really more accurately reflects what's happening now. I will tell you that personally, when I worked in the orthopedic clinic, when I was in clinic, I saw many new patient consults, saw simple postoperative follow-ups, also saw follow-ups for patients that were having problems. And I had my own clinic schedule, and I had a on-call physician that I could consult with when needed, but really was trusted based on knowledge and experience to manage my clinic. But the other thing, and this is not unique to being a PA, but really we should think about this in any healthcare field, and that is that each of us, I don't care what your role is, each of us has to be aware of what our personal limitations are, and we have to really manage our egos so that we know when to reach out in a collaborative way for advice or help. So on the job, PAs can be providers, also administrators, and this also involves taking on leadership roles. This is something that we start in the first year introducing this concept to, because one of the things that has become really a focus is that because of our position as healthcare providers in primary care, especially in underserved areas, we as PAs have to appreciate that we need to become instruments for change and improvement in our healthcare delivery system. One of the advantages is that PAs are very versatile. Most of the time, I was really unusual back in the 1988 to 89. I went to a formal training program in orthopedic surgery. That was fairly rare. Most PAs who go into a specialty evolve into it through on-the-job training, although, and I'll cover this later on, although there are now is an entire industry of postgraduate PA training programs. Because of this, we have more flexibility in work days. The family life balance is considered to be a little bit better. There are some salary scales down here. I would submit to you that this was the most recent illustration I could find, or graphic, if you will, but that these numbers are low. Our graduating class last year, so these are students right out of schools. Most of them are getting in the low six figures, and PAs that are in surgical subspecialties that have experience are earning north of $200,000 a year. The difference really, I think, is that and I think you need to be honest with yourself. The PAs that I have worked with and around that were unhappy being PAs are those who really wanted to go to medical school, and for whatever reason ended up not doing it, and quote unquote settled for going to PA school, because what they really wanted to do was they wanted to be at the top of the pyramid. They wanted to be able to make all the decisions, and they wanted to be, if you will, to use an analogy, the captain of the ship. So, you know, it's interesting when John Lennon was young, his elementary school teacher asked the class, "What do you want to be when you grow up?" And John Lennon's answer was, "I want to be happy." And the teacher indicated, "Well, John, I don't think you understand the question I was asking." And his response was, "No, I think it's you that don't understand the question that you're asking." So I think that whatever, and again, I wish you nothing but luck, happiness, and success, whatever career field you decide to go into. Just have an honest assessment of what your goals are and what happiness means to you. Because what I really want you to be when you're out there providing healthcare is I want you to be happy. Length of education. So if we look at compare not only PA but MD and NP, nurse practitioner is again to get in, very similar. You have to have a 4-year either a Bachelor of Arts or Bachelor of Science. The nurse practitioner is really moving into the DNP, the doctorate of nurse practitioner. As I said, there's now several programs that are training PAs, and they have increased their program length to 36 months, and the PAs are coming out of that with doctorates. But again, if you follow the graphic here, so it's a 1 to 4 year master's or doctorate program. Some of these are part-time. They usually do not require a residency. The total time of training, including undergraduate, is 5 to 8 years. PAs now 3 years. There are no required residencies, but we're finding more and more of our students are attending residencies, and these usually range in length from 12 to 18 months. So if you add that on, really now we're getting into the area of 12 and a half to 7 years of education. And obviously medical school is 4 years. There are some schools, UC Davis is one, that has a fast track 3-year program. There are also some medical schools and osteopathic schools that have a PA to MD transition program, which is about 3 years. But then on top of that, you're going to do a minimum of a year of rotation, and then a 2-year residency on top of that, for a total of 3 years of post-medical school training. So that comes out to a minimum of 11 years, which is a pretty big commitment. And I think this number and the expense is a factor as to why some students are electing to not go to medical school, but to choose a different path. In terms of how the salary kind of falls out based on specialty, hospital critical access is not a high percentage, but it does pay pretty well. The national average is actually a little bit higher than this based on the most recent data. But you can see, so emergency department. This is becoming real popular. Retail, convenient care clinic, occupational medicine. There have been some recent improvements in legislation on a national level that now allow PAs to see and do a determination paperwork on work comp injuries, pretty important. Rehab centers, including skilled nursing facilities, urgent care centers, and you can just go on down the list. Also, there are some differences geographically in terms of not only specialties, but geographically on how much PAs make, and it ranges high as Connecticut, Washington, Alaska, Hawaii, California. You can see the bottom 5 states here. Work setting, emergency medicine, family medicine, urgent care, orthopedics. So hopefully that answers some questions about the money. And in terms of, yes, you can make, I feel blessed in my life. I've made a very good living practicing medicine as a PA for 30 years. But the other thing that I will tell you that matters even more to me is that I think that I have, I've made a difference. I feel like both on a micro level for individual patients. And I also think that in some small way, I've been able to move the needle a little bit, especially in academics. So you may be asking yourself, what does it cost to attend PA school? And here are some of the most recent tuitions. USC is now a 36-month program. They're at the top, $171,000. So this is in-state tuition, and most of the programs will allow you to get in-state tuition. And this is just for, by the way, this is just for California. So if you want to go to PA school in California, this is what it would cost you. Touro University is in the Bay Area. I teach at UC Davis, $123,000 for the program. And again, it's a 27-month program, and it ranges all the way down. Stanford is now higher because they've gone to a longer program. So the investment in your education is not insignificant. There are PA residency programs. These are becoming much more popular. And there are currently 148 programs. I just went on the website in preparing for this talk and added them up, and they go from abdominal organ transplant to urology. Most are a year long. Some, again, are 12, 16, or 18 months. These have a stipend, so there's not a tuition to go, but you do get paid a stipend. And this is becoming much more and more popular as some of the more desirable positions are becoming more competitive. Okay, so that's all that I have, and I'm certainly open to discussion or any questions that you might have.
Thank you for that wonderful presentation. I'll go ahead and open up the floor in case any of our students would like to ask questions themselves. So if you guys would like to use the raise hand function, I can go ahead and call on you. If nobody wants to ask their question themselves, we also have compiled a list of questions that have been dropped in the chat, and I can ask those for you. Looks like
there's several questions in the chat. I don't know whether some of those might have gotten answered, but if there's any that weren't, please ask me anything.
Yeah, of course. Looks like we currently don't have any takers on asking questions yourselves, but I will go ahead and ask some that we've compiled from the chat. Actually, I see Manny has just raised their hand. So if you want to go ahead and ask your question, take it away.
I didn't put the video on. I apologize. Hi, Mr. Edmond, how are you?
Good. How are you?
I'm good. So do you believe that an individual who would go through the residency program would be at a higher advantage than an individual who did not?
That's a really good question, and I'll answer it with a little bit of a story. So when I was working here in town, I had a friend who owned a physical therapy office, and he had a physical therapy assistant named Jimmy. That was literally his name, who was looking at either going to school to become a physical therapist or a PA. And so Mike, the owner of the business, said, "Hey, Phil, would you mind meeting Jimmy? Maybe for lunch, he has some questions." So we developed a relationship, actually played indoor soccer together. And Jimmy ultimately went to a PA school, went to a program, and wanted to get into sports medicine. So he elected to do a postgraduate training program. And we, we stayed in touch. We still have a relationship. And I asked him that very question. I said, "Well, look, what did you feel like for you the advantage was of doing a postgraduate training program?" And he felt like essentially what it did was it basically gave him about 2 to 3 years of an equivalent to on-the-job training. So he felt like, first of all, he felt like he was at a major advantage in terms of getting the gig, getting the job, because he'd done the training program. And then he felt like once he got into the job, he felt like he was about 2 to 3 years ahead of somebody who came right out of school and was trying to learn things, kind of on a day-to-day basis.
I
Thank you
got
for
you.
that answer.
Thank you.
So Miranda is asking, what is the average age range for patients you see while in the sports medicine specialty?
Well, I actually had, I don't know that there was a typical range. Well, obviously at one point I was on the adult reconstructive surgery, and what that involves is people who are undergoing either primary or revision joint replacement. So those obviously were older patients. But I also did, a significant part of my practice was general orthopedics and trauma care. And so, that really involved, everything from kids doing crazy nutty things that we all did as kids, falling down and hurting themselves. And then, the older patient who had a fall at a skilled nursing facility, who now presented to the ED with a hip fracture. And I would say, really essentially everything in between. But I will say this, that for instance, if you had a penchant that you really like kids and wanted to take care of kids. I mean, I work with some pediatric orthopedic specialists, and their practice really, ended when your patient turned 20 years old. So you would really be able to, within the realm of orthopedics, zero in on whatever you wanted to.
Thank you for that answer. I see that one of our students, Jake, has his hand raised, so you can go ahead and ask your question.
Good afternoon, Dr. Emond. How are you?
Good. How are you?
I'm doing very well, sir. No, thank you for asking. Just one question that I had when looking at the prices, the tuition for the different PA schools. In your professional opinion, is there really much of a difference between the different schools that we go to, depending on like the tuition, or do you think that should not play a factor at all in the education, in your professional opinion, sir?
Well, that's a really good question. That's a really good question. I mean, at the end of the day, what you want to do is you want to get out there. You need to get certified. You need to get licensed in a state. You want to be a competent provider, and I think that there are all of the programs that are certified. And I think the key thing is your program needs to be certified, and we have a separate independent agency that monitors that. So I don't know that there's a huge difference. I do think that one of the most important things is that you should choose a program that kind of aligns with your interests and your values. And what I mean by that specifically, like for our particular program, what we have set out to do, and this is not by accident, this is on purpose and is stated on our website in terms of what our goal, what our mission statement is. And that really is to fill the gap in primary care medicine to underserved, underrepresented populations. So obviously we have students who choose our program because they, they have that same passion. That's what they want to do. So I mean, I wouldn't, you know, I don't think you can make a correlation that, that if you go to the most expensive program, well, gee, that's the best program. I think what you need to do is find the best program for you and then take a look at what the tuition is.
Thank you
All
for
right,
that
thank you very
answer.
much,
It's
sir.
really important to see your individual path because everyone's different in their journey. So I see Cassie has their hand up. So Cassie, you could put your hand down and unmute.
Hi, Phil. Thank you so much for your time. I truly hope that I can get into your program this upcoming cycle. My end goal is to end up going through a residency for orthopedics. So this was an awesome presentation for me personally. I'm wondering what is considered a minor procedure or surgery, and also what's your personal favorite?
So each state has a little bit of a different regulatory system and laws. Within the state of California, I can perform any procedure that is done under local anesthesia. So at least theoretically, I mean, we are doing more and more of these cases under local anesthesia. I mean, when I was in the military, I was doing routine knee arthroscopy under local anesthesia.
Okay, thank you
That's
so much,
so
Phil.
interesting. Thank you for that answer. That's really cool. I see another one of our students, Melody, has her hand up, so you can go ahead and ask your question.
Hi, so my name's Melody and I am applying this upcoming cycle and I'm very interested in the Davis program, and I was just wondering, since the PA students take so many classes alongside NP students, if they're ever influenced by or end up learning the nursing model, even though you said that the PA program does typically follow the medical model.
I think, here's what I think. I think it's the best of both worlds. And I think, so what we can, in medicine, and I'm in medicine, we can learn something from the nurses. And I think what we can learn is, honestly, and I'll just be blunt, I think that they have figured out some of the key elements of communicating with people, like on an individual one-to-one basis, a little bit better. I think also they have really moved in a more holistic approach for a longer time than we have. And I think that because of that, they tend to look at the whole patient and have a real focus on a more longitudinal approach and a patient-centered approach than maybe we have in medicine for a long time. So I think the way that we teach our clinical medicine courses is based on the medical model, but we have stolen some of those elements from our nursing colleagues and have integrated those. And I will tell you that in 2 years, the NP program and PA programs are going to go their separate ways. And it's not a bad thing. It's just an evolutionary thing. But even when that happens, we're not going to lose some of those elements. We're not going to lose some of those elements. Yeah, we kind of stole them from our RN counterparts, and we're not going to give them back.
Thank you so much for answering that.
Great. So another student, Manny, has a question. You can unmute, Manny.
Hello again, Phil. I was just wondering, because I currently have a job as a CNA in a assisted living skilled facility, and I also have a job as a pharmacy technician in training. I was wondering what your opinion was on which would be a better role for the PCE, as I feel pretty overall I'm taking on both of those.
So, I mean, you're asking which one would be better in terms of enriching you in terms of patient experience. I mean, I don't know. I think the advantage of being a CNA is that you're in the trenches with the patient, but I think that there's are maybe some science aspects to working in a pharmacy. So I mean, I don't know that I would favor one over the other. And I think you can go on our website and see what our prereqs are. We require the number doesn't come off the top of my head, but we require a fairly significant number of patient contact hours. And the one thing that people tend to gravitate towards is that they'll become scribes. And I will tell you that as a person who is on the admissions committee and evaluating the applicants, I don't know that that's ideal, because you're kind of stuck somewhere in between. You're not really in the trenches providing patient care. You know, I don't know that that's ideal. I would try to, what I would try to do is, rather than be, you know, singular, I would try to maybe expand things and do a variety of things. Maybe have some scribe background, maybe have some CNA background, maybe have some pharmacy tech background. I think this enriches your application, and also it enriches you, I think.
Thank you very much.
Thank you for that excellent answer. That's super insightful. I see we have another student, Justice, with his hand up, so you can go ahead and ask your question.
So, hi, on the topic of patient contact hours, are applicants who are fresh out of university, you know, 20-somethings, versus applicants who may have had a like cemented career in maybe paramedics, or, you know, with thousands of hours of experience over many years, comparing those two applicants, is one favored versus the other, really?
Well, I'm assuming you want me to be honest, so I will. Yeah, I think that here's the problem. I'm just being brutally honest with you. The problem is that you take somebody out of high school, and in Europe, they do things a little bit differently. I was honored to go over in January of 2019 and help a friend of mine set up some of the orthopedic curriculum in the first and only PA program in Ireland, in Dublin. And they have kind of a 6-year program where the students come right out of high school and go to quote unquote medical school. I will tell you this, and I'm not trying to be insensitive, and certainly I don't want to insult anybody, but as you can imagine, the evolution from getting a 4-year degree to having a patient sit in front of you and having to have a difficult conversation with them, or having to make life and death decisions, involves something way, way, way beyond, you know, intellect or memorization of facts or education. What it really involves is your growth as a person and your maturity. So I will tell you that that we tend to favor people who have a little bit of mileage on them, if you will, a little bit of experience. You know, yeah, I've been out there and I've done that. And here's what we have found. I'm just going to be brutally honest with you. PA school is shorter than medical school. It's not easier. It's not easier. So at the end of the first year, we do some tabletop patient-centered exercises with the medical school students and the PA students, and I facilitate one of the groups. And our PA students at the end of the first year are running circles around the medical school students, because it's a different model. We don't have 4 years for you to grow and mature and develop things like sensitivity, empathy, you know, critical reasoning. So we do tend to favor people, I think, on the front end who have a little bit more experience and have been through life's ups and downs. And PA school is really hard. And we have found that, you know, people who've been punched in the gut a few times tend to do a little bit better in PA school.
Thank you so much for that answer. It was really well worded. So we have a student, Miranda, who has raised her hand. Miranda, if you can unmute and ask your question.
Hi, Mr. Emond. So orthopedics is something I'm very interested in, and I was hoping you could just kind of walk us through a day, whether there was OR or clinicals, just kind of like what it would look like, and like the percentage of time you spent on administrative duties versus like time with patients.
So I'll address your last point first. So one of the advantages of being a PA versus an MD or DO is that I was a senior lead PA in the, I work for Kaiser Permanente. So it's a very large staff model HMO. And in our department, there were eight surgeons and 12 PAs. And as a lead PA, I did have some administrative duties in terms of, you know, doing schedules. And then if there was some issues with PA performance, we kind of wanted to handle it ourselves. So the administrators would come to me, and then collegially, obviously, we would then sit down and try to figure it out. So the administrative burden is much less. Now, in terms of what every day looked like, it depended on what the day was. I would say that out of a 5-day week, 2 to 3 of the days I would be in the OR. And what that meant was, because somebody asked a question about first assisting. So back in the day, the way it worked was you had a surgeon and a first assist who was also a surgeon. Well, we have now evolved in terms of training and experience, and we can fill the role of the provider that's across the table from the surgeon. And we have the skills to be able to perform as a first assistant surgeon. So that's essentially what we do. We literally fill that role. And again, 95% of the surgeries, big and small, were done with an MD, DO, and PA. Did not require another surgeon. So 2 to 3 days a week, we would be doing that. Then the rest of the time we were in clinic, and we saw somewhere between, I don't know, 20 to 30 patients a day. Interestingly, within the Kaiser system, most of the new patient consults were seen by PAs, because Kaiser felt like if they were going to hire surgeons and they were going to pay them this kind of money, they wanted to pay them to operate. So we facilitated that. We saw most of the consults. The other thing that we did was we ran the inpatient service. So every week, one of us would be on call, and we did all the rounds. We managed all the patients. We did all the daily rounds. We facilitated discharge or transfers. You know, we did all the transfer orders. We did all the discharge summaries, all that stuff. And then we were on call for any cases that had to be done. We also responded to calls on a limited basis to the emergency department, and we would be the first provider to evaluate the patient in the ED.
Awesome. Thank you very much.
Thank you for that answer. That's super helpful. I see we have another student, Chris, with his hand raised, so you can go ahead and ask your question.
Yeah, you pretty much answered just about the first assisting in the surgery, but I was curious if you could elaborate just a little bit more on like what differentiates the role of the surgeon versus the first assist, if that makes sense.
Yeah, well, I think it really depends on two things. I think it depends on the case, and it also depends on the experience on both sides of the table. I mean, there was a time I remember where I was on call on a weekend with a surgeon who was an adult reconstructive specialist that only operated on hips and knees, and a patient came in with a septic shoulder. And at that time, I was on the upper extremity team. So we operated on shoulders every single day. And in that particular case, I literally did the case, and she assisted me because I had been doing this, you know, 2 or 3 days a week, and she had not operated on a shoulder for 5 years. So the distinction between the two can be blurred. And so I mean, even some other surgeons, they might raise their eye, but remember, the most important thing is, I don't care who or what you are in life, is you have to be honest, and you have to know your limitations and accept them, and you have to use the resources around you. So I did not see that as a sign of weakness on the part of the surgeon, because trust me, there were some surgeons that were stubborn that would have never done that. We would and the case would have been a struggle. I saw that as a strength on her part. And by the way, super good friends. We're still close, and have an incredible amount of respect for each other. And you know, the other thing that happened, which is interesting within the trauma service, was that the PAs did most of the fracture reduction. And in fact, we did it so much, we actually became at least as good, if not better, than the MDs who were trained in it, but hardly got to do it because they were up in the operating room. And, you know, I mean, it felt good to me when one of the orthopedic surgeons' kids came in with with you know, with a broken wrist, and they literally found me and they said, here, I want you to reduce my kid's fracture. So that made me feel pretty good.
That's amazing. Thank you for your answer. Miranda asks, what part of your PA career was your favorite, whether it was working in the clinic, doing surgery, or teaching?
Boy, that's a good question. Well, right now, my favorite part is teaching. But prior to that, I think what I liked the most was I like people. I'm a people person, and I like getting to know the patients in the clinic. And I felt like in the orthopedic realm, we were able to actually fix most of the problems that came through the door. And that, to me, that was rewarding. You know, have somebody who came in with horrible hip arthritis and they literally could only do transfers from bed to wheelchair, and then we do a hip replacement, and 8 months later, you know, they're out walking around the block. I'm not, you know, or maybe doing a mile walk. That was awesome.
Awesome, thank you. I see we have another student, Emma, with their hand raised. So you can go ahead and ask your question.
Hi, I was just curious as to how your job as a PA had changed during the pandemic. What were the biggest changes that you've seen, both in the teaching setting as well as the clinic setting?
So I was retired from full-time clinical medicine by the time this awesome virus hit us. So I only have experience how it changed things academically, and obviously it was a complete shock to the system because we couldn't do anything in person. We had to reconfigure absolutely everything that we did. We have a concept called standardized patients, where they come on campus and the students, you know, learn how to do skills through the grace and services of those standardized patients. That was all gone. So we had to teach things in a completely different way. And I'll let you in on a little secret. I'll let you in a little secret. Not everything is bad. Not everything that is bad is all bad. So nobody likes the coronavirus, and it's horrible. And one of the things that it's done is it's disconnected us a little bit on a person-to-person basis. And we're all getting COVID Zoom fatigue for sure. But you know what, like anything, there were some really awesome things that came out of it. And so we changed the way we did things. We did Zoom-based, you know, case-based groups, where I would sit for an hour or two and go over a case in detail with 10 or 12 students, and I would act as a patient, and they would, you know, go through the workup of the presenting chief complaint, and there was a lot of direct feedback. That was awesome. We love the way we did that. We also, in our particular program, started a course on clinical documentation that we hadn't had before. So we learned some things, and we learned some things that even when we are back in person and we are no longer under any restrictions, we're not going to stop doing those things. So it's been a bad learning experience, and it's been the most awesome learning experience. You know, Charles Dickens, it was the best of times, it was the worst of times.
Thank you for that awesome answer. Despite the Zoom fatigue, I thank everyone for being here and for you presenting, even if there's Zoom fatigue. So a student, Cassie, has her hand raised. Cassie, you can unmute.
I just have a question for people trying to raise their GPA with how classes have been virtual and pass, no pass. What your suggestion is for them? Do they just take the class and have the pass? Because it doesn't really show you've improved from the previous time and your GPA doesn't change.
Well, you know, I think that what you have to do is you have to work with the situation and circumstances that you're given. I mean, if you're, you know, if you're trying to raise your GPA, and you can't find like especially, let's say, an advanced science class that is GPA graded, but it's like you said, pass or fail. You know, here's what I would say: two things. The first thing is, that's still not all bad, because one of the things that as a, somebody on the admissions committee looks for is are people who have enough introspective aspect to their lives that they can identify their weaknesses. And if you end up in a course because you have to take it virtually and you get a pass, that still means something, right? It means you've identified your weakness and you did something about it. But the one thing that I would tell you is that if that is your situation, that's important, and you need to put that in your candidate statement. So when you are writing your candidate statement, I don't care what program or field you're going to get into, just realize that whoever's reading your application doesn't have, an hour or even 30 minutes to go through every single page. So the candidate statement not only needs to be compelling and tell me something about you, so that at the end of it, by the time I'm done reading it, what I need to feel is not this, but I need to feel like, oh my God, I really want to meet this person. But the other thing is you need to help provide us a roadmap, because, I may look at that and I'm thinking, well, did you have a, so you didn't even bother to take this class where you got a GPA. No, that's not the issue at all. In fact, you took the initiative to improve yourself, but unfortunately, because of circumstances beyond your control, you weren't able to affect your GPA. But look, it's not just about a number, it's about improving my knowledge base. Help us help you by pointing that out in your statement.
Okay, thank you so much.
Thank you for that awesome advice. We have another student, Abigail, with their hand raised. You can go ahead and ask your question.
Hi, so I was wondering, a lot of what you spoke about was working with your situations in the pandemic and kind of, using those to your advantage. Would you say that in the area that I live in, it's very difficult to get shadowing at this time, but I have an opportunity to shadow a nurse practitioner? Would that be something that would be valuable to me, or is that something that isn't going to be really useful on my track to being a PA and to applying?
Well, in our program, I would say that we don't consider it any less valuable than shadowing a PA. You see, I mean, I'm not about, here's the deal, and think about what I'm going to tell you. Are you ready? Let's suppose something bad happens to you and you're now the patient and you're laying there and you're hurt, you're in pain and you're scared and you have anxiety and somebody walks in the room. To me, I want somebody to help me. That's what's most important. I want somebody who's ready. I want somebody who's competent. I want somebody who's compassionate. And that matters to me more than what initials are after their name.
Thank you.
Thank you so much for offering that different perspective. We have a student, Joshua, who asks a very important question. He wants to know what it really means when it says that PAs are under physician supervision. How are they supervised, and can you kind of talk about that?
Well, so things are evolving. So in the old system, you literally were assigned a supervising physician who was responsible for your care. And this manifested, they had to review a number of your charts. They had to countersign your charts. They had to countersign some of your prescriptions, and really, had a very, very close supervisory relationship with the PA. This has now evolved to the point in California, the word collaboration is being substituted, and it's no longer mandated at the state level. And instead, what the state, which I think in a very intelligent way is doing, is allowing these decisions to be made at the practice level. For instance, here's an example. Within the Kaiser system, with 30, first of all, nobody knows everything. We all need help with something at some point of our lives. But obviously my knowledge base and experience with 30 years of experience was different than somebody who had just finished a postgraduate training program and hadn't worked a day you know, in a paying job in the orthopedic field. And prior to the passage of optimal team practice in California, we were required to be treated the exact same way. And now with the passage of OTP, the docs and the PAs in the clinic get to decide how much collaboration you need. And this is really based on the individual. Oh, I might also say that there are now 3 states where they pass full practice authority for PAs, and PAs can now basically just open up their own practice.
Thank you so much. That's so interesting to hear. We have a question from one of our students, Lorelei, asking about your relationship with your patients as a PA. Could you elaborate on that for us?
You know, I think, well, it was great. It's what kept me going every day. It was what kept me going every day was and people talk about burnout. I don't know what that is. I didn't know what it was, because I felt blessed to be able to provide the care that I was providing to my patients. And I felt like I was placed in a position, and here's the way I looked at it. And regardless of what field you go into, you might think of it this way. Let me tell you what, attitude is everything in life. Attitude and beliefs is everything in life. And so the deal is this. The deal is that you have a 20-minute slot on your schedule. And that 20-minute slot is a 20-minute time period where you're going to spend time with your patient. And you can look at it from your perspective that it's another 20 minutes. And there's another 20 minutes behind it. And there's another 20 minutes in front of it. But think about it this way. For your patient, that might be the most important 20 minutes of their entire week. So I looked upon the ability to practice medicine as a privilege and a blessing. And my job, not all the time, because I can have bad days too, but my job was to walk in and for each and every patient that I saw was to make that 20 minutes very valuable for them. I wanted to meet their needs. And let me tell you what, it didn't just benefit my patient. I actually got more back from it than my patients did. It was better for me as a human being. It made me a better person. So that's kind of how I look at the relationship. And I don't think, so my relationship with my patients as a PA was not different in any way at all than the relationship with the MDs. In fact, sometimes because I felt like we're trained to be better communicators, to relate on a more individual basis, my relationship with the patients was more rewarding for me than it was for the busy surgeons. And honestly, I think some of them, they were a little bit jealous of this because of this. So I think the reality is that we're all healthcare providers on some level, whether you're a CNA or you're, you know, a Nobel laureate, MD or DO. We're all healthcare providers, and we all are going to benefit from our interactions with our patients.
Thank you so much. I think that patient interaction is pivotal to any healthcare field. John B. wants to know if you could elaborate more about the path following the surgery program in PA.
I don't know, John. I don't know that I really understand what you're asking. I want to answer your question. So can I ask you to expand on exactly what you want me, what information you need? John may not have a microphone. I didn't think about that.
All
right.
Good morning, sir.
I will try to answer the question. So the program that I went to was a year long, and we were basically, the PAs were the house staff. There were no orthopedic residents or interns. So we functioned as the intern / resident for a year and ran the inpatient service, and then obviously got up to speed in terms of our surgical skills. And again, and I experienced the same thing as my Jimmy story. When I got to my first base, which was right here in Sacramento, I was the first orthopedic PA that they'd ever had. They didn't really know what one was, but I felt ready. I was ready to start seeing patients and help in the operating room from the first day that I stepped into the clinic.
Awesome. Thank you so much. We're going to have one last student question. And this question is about international medical graduates. So do you find that it's harder for them to get into the US healthcare system? Are there certain professions that are better than others in terms of that?
Sure, I will. So, I mean, the most experience I have is with the PA career field, and I will tell you that. So, although we are educating the medical model, I think that the breadth and scope of our education is a little bit different. And there was a period of time, there were some states that were allowing or authorizing international medical graduates to actually take the PA certification exam. There was a pilot program. It didn't go great. It did not go great. The certification exam is pretty rigorous. And right now, I'll tell you that the way the laws and regulations are set up now is that you cannot take the certification exam to become a PA unless you have graduated from an accredited PA program. So, I mean, I can speak to that. I know, in terms of medicine, getting a medical license, things are different. There's obviously an exam you can take to at least start that process, but it's different. And again, I am not, that's not my area of expertise.
Thank you so much for your wonderful presentation. I know myself and all of our students learned a lot. So considering this, we would like to encourage everyone to reflect on today's session. You can ask yourself what brought you to the session today, what are 3 major takeaways you got, and what do you want to learn more about? This writing or reflection is not required. However, we do encourage you to submit it to our website for publication for recognition of your hard work and your meaningful reflections. And you can use your reflections to document your experiences and thoughts during our presentations or just to enhance your future applications. So if you want to learn more about pre-health shadowing and get involved with our program, you can volunteer with us at our website and get certified hours through professional nominations, graphic design, social media promotion, and so much more to have an active role in PHS and lead projects and initiatives and even be up here with us. So thank you. Once again, we are humbly asking that if you are financially able to donate, that you please consider sending a few dollars to us via Venmo or PayPal. The link is in the chat. It costs a lot to keep our program running and free to all of you. So if you are someone who can afford to, or if you know someone who can, please support those who cannot by donating to our organization so everyone can continue to get the education they deserve during these times. Otherwise, we simply ask you to spread the word about pre-health shadowing so many more students can join our sessions and take away virtual shadowing hours and get experiences. So now for the part we've all been waiting for, earning a digital certificate for the virtual shadowing hours from this session. First, you are going to go onto our website and find our professionals course pages. Next, you can take our quick 10-question multiple choice quiz based on the content from the session today. You will have 30 minutes per attempt to earn a 70% or higher to get your certificate. You do have 2 attempts to take the assessment. The quiz is open indefinitely, so you can take the quiz tomorrow or a month from now, but you do have 30 minutes to take the quiz once you open it. Once you have passed, you can click the Finish Course button at the bottom of the Professionals page and download your certificate to verify your virtual shadowing hours for today. If you happen to miss a part of the session or you just want to go back and view this session and other sessions that we have recorded, you can definitely go onto our YouTube channel where we post every session and you can find the recordings there. And you can also find them via the professional pages on our website and take the post-shadowing assessments on any session you find interesting. So last but not least, be sure to follow us on our social media and subscribe to our email list for the latest updates on upcoming sessions and events. We are currently booked every weekday until June for virtual shadowing sessions, so I hope to see you guys there in our future sessions. thank you so much for joining us today, and thank you so much for your presentation, Phil. Please stick around if you have any questions. Myself and other team members will be happy to answer them. The shadowing sessions is officially over, and I invite everyone to log off.